I'll start off. Speakers usually arrive here and say it's a pleasure to be here in Dublin. Well, actually, I've kind of got a bone to pick with you guys. I spoke at this meeting about 3 or 4 years ago, and I started off, as I often do, it was shortly after the Queen had been here and apologised for various actions over the years. And I made a comment that I wanted to apologise for the proclaimers, all right? Now, it got a laugh. It was fine. That was okay. Started off, moved on. But unfortunately now, you cannot do a lecture in public without it appearing on YouTube. Now, again, one of the good things about having kids is it gives you someone that you can really embarrass and appall on a fairly frequent basis. But the problem is occasionally they'll search you up on YouTube, and I don't mind looking stupid or unfashionable in front of my children. But the problem with the recording was I made the joke and it was a tumbleweed moment. There was not a reaction. So of course it went round all my kids' friends, check the nick of him, look at the embarrassment he is. And I looked like the least funny guy ever. So this has been recorded. I'd quite like it if I do make a joke, all right, it's unlikely now because we're overrunning. If I do make a joke, I'll go like that, all right? So just as a rerun, I'd just like to, thanks very much. Before I start, I'd just like to apologise for the proclaimers. Fine, right, okay. We're overrunning, but I'll bring this in time. We'll have plenty of time for questions, it's no problem. We've heard a lot tonight about power. We've heard a lot about the power of devices. We've heard a lot about the power of science. We've heard a lot about the power of patients and their families to get things done. And I think what I want to really focus on today, there'll be a few figures and a few tables, and we'll talk about some things, but I want to focus on actually the power of the individual patient to plan for themselves and get things better for themselves. Not a doctor's job to do that. This is the power for patients to make things better for themselves. And so when we're talking about pregnancy, I'll give a wee bit of this. There'll be some tables and there'll be some proposals at the end about what I think women of reproductive age should be doing about looking after their own epilepsy. And if I keep speaking this quickly, the people with the sign-in will be exhausted by the end of it, is it? The phrase game changers. You know about the phrase game changers? Well, not all game changers are good. I don't know if any of you know what that is. That's something that as a child in the 60s and 70s, I remember focusing on the news all the time. Thalidomide, okay? And this changed things for medicine. It changed things for the pharmaceutical industry. They realised all too late that using drugs in women who were pregnant could have serious effects. And this was way down the line. And probably the industry and the medical profession were too slow in picking this up. They didn't do the proper job at the start of screening it. They thought all the animal models were fine, so the drug was going to be fine. They didn't do the proper models for screening it, and at the end of it, too many people were harmed with thalidomide. All around the world. Australia was where it was discovered, and Germany was where it was most prevalent, but there are people in the UK. And the other shameful thing was that we saw a company who were in charge of this, and this dragged on for decades before they made reparation. In fact, there's still some here. We know for decades, centuries, that people with epilepsy have been told, oh, you don't want to go getting pregnant, you don't want to have a family. And there are sometimes reasons about passing the gene on. We heard about genetics earlier on. There's sometimes reasons about the harm that's going to happen to you if you happen to be pregnant and you're on treatment for epilepsy. So is all this doom and gloom justified? Should this be affecting the decisions we make as to whether or not we discuss having children with our patients and persuade them yes or no? And these are the questions, and we'll go through them. This is your average neurologist. I mean, this is actually one of the cooler dudes in British neurology, all right? But when it comes to making decisions about epilepsy, okay, every neurologist and every patient might feel they find themselves between a rock and a hard place, all right? I was going to put Glasgow there. I thought, no, too easy, not moving on. Sorry. Right, okay. This is the usual balance, okay, with any patient on anti-epileptic medications. You're trying to balance the idea of side effects and getting enough control of the seizures. And we heard earlier on, we were talking about quinidine, that the reason that was not going to be an effective anti-epilepsy drug was that you'd be given it and it would cause too many side effects. So this balance is really important. And that's what we're dealing with and patients are dealing with on a daily basis. This is complex enough. Once you start putting in the possibility of pregnancy, things become even more unstable. You've got the whole idea of looking after not just the mother's health with preventing seizures, but the fetal health as well. And this is something that's become a real concern over the last decade or so. And I think we've got to put this in perspective. And all the time, you don't want the mother having seizures either. Because the mother having seizures is not just putting herself at risk, but it also might be flag up some problems for the fetus as well. Anyway, we're going to deal with pregnancy and anti-epileptic drugs in pregnancy really depends on the big four questions. Is epilepsy making the outcome of pregnancy worse? Is the pregnancy going to make the epilepsy worse? You're going to lose control because you become pregnant. Will the anti-epileptic drugs cause harm to the developing baby? And will pregnancy really make the drugs become less effective or lose their effect with time? And all these questions have been asked a lot over the years. First off, do women with epilepsy have worse outcomes? Now, you'll see that this is called an odds ratio, and anything over 1 suggests that there is a higher risk in patients with epilepsy. Now, we had a lot at this conference over the last couple of days about the effect of epilepsy on a whole raft of parts of life. Increases deprivation scores and problems with other illnesses, and there are a very wide range of really quite subtle effects on all aspects of life. So what can we take from this? We can take from this that actually patients with epilepsy have a slightly higher risk of a lot of these things, having to get a caesarean section, slightly higher risk, developing blood pressure problems, having to have their pregnancy ended early with induced labour, or perhaps having difficulty with premature rupture of the membranes. All these things are a wee bit more common in patients with epilepsy. Is that terrible news? Is this all doom and gloom? Well, actually, there are a lot of other diseases who will have that range of abnormalities as well. Whether it happens to be insulin-dependent diabetes or non-insulin-dependent diabetes, whether it happens to be other endocrine conditions or other problems, will have that as well. So what I'm saying is there is an effect there, but epilepsy is not unique in this, and there are a whole host of other factors that contribute to it. And if we know about this, and that actually there's good planning, and we'll come back to this later on, about monitoring pregnancy and working well with the obstetricians as well as with the neurologist, actually would expect good plans to be made in advance of these things becoming huge problems. In terms of fetal health with babies once they're born, are they able to perform as well? Well, there is some association. We look at thousands of pregnancies, you do see changes there. But again, these are not inevitable. Any changes in proportionate risk are slight. They're there, but they're slight. What about the epilepsy during pregnancy? This has been a big concern. Lots of women's pregnancy, epilepsy gets a lot worse during pregnancy. Well, actually, you can see that unchanged and better seizure control, over 80%. So for most patients, epilepsy seems to respond well during pregnancy. There are a small number at various stages of the pregnancy where you'll get a slight increase in seizures. There's some with this massive series where they couldn't quite work out exactly what this is. And again, other series have suggested 2/3 are completely seizure-free during pregnancy, 2/3 of patients. You'll have about 1 in 6 or so will have a generalised seizure at some point during pregnancy. And again, usually that sticks with patients who have had seizures, generalised seizures, in the year or so before. Because when we look at this risk of this, people who have badly controlled epilepsy will tend to have seizures during pregnancy. Okay, so well-controlled epilepsy usually will stay well-controlled. It's got a much higher chance of staying well-controlled. And sometimes it's related to the type of epilepsy you've got, whether it's focal onset or generalised onset, or if you're on a lot of medication, which of course is just a marker for having a more severe or less responsive epilepsy. Mortality in pregnancy. I want to bring this up. Someone else mentioned SUDEP earlier on. I think that there's one major message here. Back in the 1950s, this is a survey that goes on every couple of years, and it used to just be the UK. It started in the 1950s, and now it involves UK and Ireland as well. The death rate in pregnancy has gone from 90 for every 100,000 pregnancies down to 3 in every 100,000 in the last 50, 60 years. Things have moved on. Interestingly, all the work that's been done has really brought down the biggest causes of mortality in pregnancy, all the obstetric problems, the bleeds, the eclampsia, all the sort of obstetric problems that used to really cause so much grief in these 90 women out of every 100,000. So our work there has really brought that down. What we've found is that other medical conditions in pregnancy can still cause problems. Blood pressure, strokes, epilepsy, They're slightly less common and slightly less troublesome than they were, but while we've been really successful in bringing down obstetric causes of death, we've not been quite as good at bringing down these other causes. The other thing about pregnancy and epilepsy, and this is where it's unique, is that there's a slightly higher risk of death related to epilepsy, death during pregnancy in patients with epilepsy, which is present during the time of pregnancy, but for reasons that we'll come to, that increased risk seems to persist a wee bit in the year or so after. Okay, and we'll talk about the measures which again are within patients' gift and within doctors' gifts that hopefully can help reduce the chances of this happening. So epilepsy, when we look at obstetric death, is unique in that the risk is increased during pregnancy and in the year after. Why would epilepsy get worse in someone who's pregnant? Well, actually, a lot of it we think is down to this idea of people stopping taking their tablets because they're worried, oh, those tablets are terrible. Those tablets are really dangerous to take. They'll really harm the fetus, and that women sometimes will stop taking them without medical advice. They'll not reduce the dose, they'll stop taking them. And this, of course, leaves them at risk of severe seizures, which, of course, leaves them at a slightly higher risk of coming to harm. Of course, the other thing in the year after delivery, of course, is sleep deprivation. And we know that lacking sleep, and plenty of people in the room know all this too well, if you're too tired and you're not getting enough sleep, your seizures become a bit more common. There are some changes in the drugs, and we'll come on to this later on. There are some changes in the drugs which mean that your body breaks them down a bit faster and the levels in the blood can sometimes drop. And that can then therefore lead you a wee bit more at risk. And there is a possibility that in some people, hormonal changes themselves without any other change will leave them at slight risk of increase in seizures. We come to the next bit, and this is the thing that causes a lot of harm. Now, you could argue this is a rebound effect from the whole thalidomide problems in the 1960s and 1970s, that actually we've really focused in on drugs and how much harm they can do. This is a shorthand for the drugs, and the drugs that we know something about in pregnancy: carbamazepine, lamotrigine, levetiracetam, sodium valproate. If there is a villain of the piece, and one that we always think of as being the worst, it tends to be sodium valproate. Okay, now you can see here, women who aren't exposed to anti-epileptic drugs, the risk of an MCM, a congenital malformation, is around 2.4%. So about 1 in 40, okay, the pregnancies will result in a major congenital malformation where there's no drugs involved. We can see that a lot of the newer drugs, lamotrigine and probably levetiracetam, although we know a wee bit less about that than others, don't seem to raise that incidence too much at all. Okay, so that's one of the big advantages of these newer drugs. Carbamazepine doesn't have much in effect, but sodium valproate does have an effect. Now, I want to stress this here. This is not a reason for anyone to make hasty decisions about their drug treatment in advance of pregnancy. And the reason for that is that you can look at this, you can say, 2.3% versus 6.7%. Oh, that's a big rise. Well, there's an important way of framing this, which is 97.5% of pregnancies will not have a major congenital malformation if there's no drugs, and actually around 93%, 92.3% will have no major congenital malformations on sodium valproate. So even as a worst case scenario, it's not a 50% risk or a 75% risk. Let's put this in context. There are ways of minimising this, so there are things we can do in advance of the pregnancy to make things better. That's what I think we should be focusing on today, because for some women, sodium valproate is the only drug that will control their seizures. Focus in on this. And again, it's a complex thing, but the whole reason for showing it is that actually if you reduce the dose, you tend to reduce the effect on the fetus. And this will lead to one of the recommendations we've got. Not that you rush in and make any hasty decisions about stopping treatment or I'm going to stop taking it for the first few months. This is why we have to have a reasoned discussion about this before people become pregnant. We know that mixtures of drugs are sometimes thought to be unhelpful to the fetus. What we've got to remember is that mixtures of drugs are given for good reason. That's because it's severe epilepsy. We only give mixtures of drugs when we have to. So those are the patients who tend to need tighter control of their epilepsy and more aggressive treatment of their epilepsy. The other thing I will say, and you may read about this, idea that sodium valproate, as well as a congenital malformation, a structural change in the baby that can sometimes happen with drugs. There is over the last 10 years or so, this emerging picture that sometimes the IQs in babies exposed to sodium valproate are felt to be slightly lower. Now, it's a relatively modest effect here, about 9.7 average points in the IQ. So it's a relatively modest effect. Not want to minimise it. I wouldn't want to rush round decreasing everyone's IQ by 10, but I'm not minimising it, but it is relatively modest. And there are things that we can do. We can look at different drugs, because there is a thought that carbamazepine and lamotrigine don't appear to have an effect, and that actually, again, with sodium valproate, the crucial thing here, if you can manage to drop the dose, the effect on IQ appears to get less as well. Does pregnancy make the drugs become less effective? Well, we've mentioned about things that might reduce the effectiveness of drugs. The other thing, of course, is that sometimes the kidney and the liver work differently in the drugs. We know that sometimes the bowels and the gut doesn't work too well when people are pregnant, and the whole change in fluid content and all the technical terms that brings along. This is my worry at the bottom here, which is without proper consultation or discussion, that there's spontaneous and sometimes patchy decision about whether or not to take medication. So it's stop, start, and I don't think that's good for anyone's epilepsy. We know that this effect of the way the body breaks down drugs can have an effect on lamotrigine and levetiracetam. So we know they're good drugs, but we also know that during pregnancy, sometimes you can't always be absolutely sure that your drug level will be the same as it was in the months before you were pregnant. And that can sometimes lead to some need for closer monitoring during pregnancy. But you know what? It's another example of something that should be discussed and planned, hopefully, before pregnancy. This is when you look at patients on a single drug and how many patients who are seizure-free before remain seizure-free during pregnancy. And we can see that for levetiracetam and lamotrigine, it appears to be slightly lower than with other medication. The reason I say this is that some doctors, and it varies from doctor to doctor, and the need for it varies from patient to patient, feel that during pregnancy you should be having blood levels checked of your medication. Okay, now checking blood levels of the new medication is not easy and it's not quick, but some people feel that this should happen on a fortnightly or monthly basis among the patients who are pregnant. That's much more the fashion in the States, but there are some centres around UK and Ireland where that happens. I'm not a fan of it. I think it often leads to other problems when we just do this on a routine basis, but I can see that there are some patients that this might be a justifiable approach. This is the most important part. All right, we've heard about a lot of really great advances and a lot of important things, but when it comes down to pregnancy, the most important thing is the relationship between the woman and the fact she's able to discuss what matters to her with her consultant, hopefully before pregnancy starts. The figure always was that in the epilepsy clinics, around 40% of pregnancies were unplanned. Okay, made me feel better because in our house it's only 25%. Right. So about 40% of pregnancies in the epilepsy clinic are unplanned. What does that tell us? Does that mean we're all doomed to lots of different surprises? No. It means that if we get our planning right, we can capture everyone and make sure that there is a safety net for most of our women who are attending the clinics. A discussion with the patient about what's important to them is probably the mainstay of what's going to form the basis of your plan. What are you worried about during pregnancy? If your control does get a bit worse and you have a breakthrough seizure, what effect is that going to have on you? Do you drive? Will it affect your work? Is it really that you hate taking tablets? Is your major worry about what's happened to the baby and nothing else? In which case that might change how the woman wants to make her plans about things during pregnancy. So the most crucial thing here is not whether or not you understand the difference between odds ratio of 8 and 2, or whether or not there's a percentage risk, or whether the dose is above 800 milligrams or below 800 milligrams. It's a relationship with your doctor that allows you to come to a consensus, a shared decision. I'm going to mention some proposals here. These are Norman's statement earlier on was absolutely right. There's no rule that you can't break. But I'm going to mention some proposals and ways that I would frame a discussion with a patient who came to me. I think any young woman who comes to me on sodium valproate, these are the questions that I should be asking every time they come. Is it epilepsy? Do you need this sodium valproate? Is there another drug that will do the job just as well that might not cause problems if you become pregnant in 5 years or 10 years? Do you need this dose? This might have gone up and you've just ramped up the dose and you needed that at a time when you were maybe, for other reasons, you needed the dose to be a bit higher. Can we manage to bring that down? This might actually involve using an EEG, a brainwave test, and working out whether there's a bit of leeway, a bit of a safety margin, just to nudge the dose down a wee bit further. Or will we do the EEG and find out there's some breakthrough discharges and actually there's no leeway for reducing the dose? All these things would come. So these are the questions that I ask every time I see a woman, and that's whether or not she's planning pregnancy next year, whether or not she's 16 and not planning pregnancy. No way, that's never going to be me. Okay, and you know fine well in 10 years, 15 years time, actually there may well have been other questions to be asked, but you need to ask this, we need to ask this. We need to ask this of our patients and have a discussion every time they come to the clinic on sodium valproate. And that fits in very much with the fairly major statements from Committee of Safety of Medicines and the health regulation authorities recently. I think folic acid should be standard in young women. Again, some people hate taking tablets, but folate's a vitamin, and a high dose of vitamin, 5 milligrams a day, is usually very well tolerated. Wouldn't expect that to cause any side effects, but I fully accept that some people just hate taking tablets, and if we're asking them to take 2 tablets a day and all of a sudden bung in the notion of taking a vitamin as well, that might not be too popular. But having said which, with a bit of discussion about why you're taking it, and actually even taking it every other day or taking it most days when you remember, actually better than not taking it at all. And if everyone's informed, then we're all on the same page, and that's fine. I think nurse review should be standard. I'll come back to this notion later on. It's one of the ways in which Ireland seems particularly well served compared to the UK is with the provision of epilepsy nurses. And I think that nurses tend to follow discussion protocols much better than doctors who are a bit haywire and kind of off the wall sometimes. Sorry, Norman. Other proposals. I think, to my mind, if we think you're at low risk of seizures, if you're previously good control, if you've got a type of epilepsy that we wouldn't expect to flare up during pregnancy, I wouldn't tend to be too interventional with checking blood levels. I think there are some patients who maybe have bad epilepsy or severe seizures or who are on specific medications that I might want to be a wee bit more interventional with. But the best person to help make that decision is not the social worker or the epilepsy nurse or the doctor, it's the doctor and the patient, or the nurse and the patient. It's a shared decision about what the plan's going to be. I think the other thing that's important here is we don't stop thinking about the interaction with pregnancy and epilepsy as soon as delivery happens. Okay, we should be thinking about making sure that people are keeping themselves safe, good sleep pattern, continue to take their medication, making sure they're not doing anything else that's going to make their epilepsy flare up. And this should be a discussion that applies to reduce this notion of an increased risk of coming to harm from seizures in the year after delivery. Breastfeeding. In general, breastfeeding's better than not breastfeeding. And that doesn't change when the mother's on anti-epileptic medications. Okay, one of the ways that one of the nurses mentioned to me was, well, the baby's been exposed to this drug for the previous 9 months, another 3 or 6 months isn't going to make any difference, particularly when we know that there are definite benefits to breastfeeding in different areas of the baby's health. I know it's complex, and I know that we've mentioned a lot of things that can change during pregnancy that might make epilepsy worse or epilepsy better, might make drugs more unpredictable or less effective. We know that. But I think with the proper plans, we should still be aiming this whole notion, few seizures, but hopefully in the fewest drugs, and hopefully in the lowest dose. And that's not a decision to be made once someone's pregnant. It's a plan to be made, hopefully before they are. And with the proper thing, we can hopefully make this whole picture a bit more stable. Thanks very much.